Hi, good night. My name is Dr. Ramrup, and today I'll be presenting on hydrocephalus, the pathophysiology and management of the disease. So, firstly, to outline our learning objectives, the goal is to describe one normal CSF physiology and circulation, briefly because we had done a previous presentation on it, explain the pathophysiology of hydrocephalus, as well as the clinical presentations, classify hydrocephalus based on mechanism and etiology, recognize key clinical and radiological features, as well as formulate management strategies, including surgical options. So, why does hydrocephalus matter? So, it is one of the most common conditions we encounter in neurosurgery, and importantly, it spans all age groups. So, from neonates with congenital abnormalities to elderly patients with normal pressure hydrocephalus. You could see it in a wide range of pathologies, including trauma, intracranial tumors, infections such as meningitis, or subarachnoid hemorrhages. What makes it particularly important is that if it's not recognized and managed appropriately, it can lead to progressive and irreversible brain injury. So to start with CSF physiology, let's just take a look at production. So CSF is produced primarily by the choroid plexus within the ventricular system, accounting for roughly 70 to 80% of the total CSF production. The remainder will come from ependymal surfaces and interstitial fluid exchange. In terms of volume, about 500 mils of CSF is produced daily, with the total volume in the system at any one time being approximately 150 mils. So CSF is turned over several times in a day. It's not a passive process, it is active and energy dependent. So it relies on ion transport mechanisms, particularly sodium, potassium ATPase pumps, as well as carbonic anhydrase activity. Following production, CSF circulates through a continuous system involving the ventricles and the subarachnoid space. So it begins in the lateral ventricles from where it passes to the foramen of Monro into the third ventricle, and it then flows through the cerebral aqueduct, which is relatively narrow, into the fourth ventricle. From the fourth ventricle, it will exit via the median foramen of Magendie and the two-paired lateral foramina of Luschka, entering the subarachnoid space. It'll then circulate around both the brain and the spinal cord before ultimately becoming absorbed into the venous system itself. The flow is generally unidirectional and driven by pressure gradients, although it is also influenced by pulsatile forces related to the cardiac cycle. So once it's circulated through the subarachnoid space, it is primarily absorbed by the arachnoid granulations, and these structures project into the dural venous sinuses, particularly the superior sagittal sinus, allowing CSF to drain into the venous system. This process is pressure dependent, so absorption occurs when the CSF pressure exceeds venous pressure, which allows CSF to pass into the bloodstream. The arachnoid granulations function as a one-way valve system, preventing the backflow of the blood into the CSF. There's also secondary pathways of absorption, including perivascular and lymphatic routes, although these play a relatively minor role under normal conditions. So also we have to have an understanding of the Monro-Kelly doctrine. So the principle of this basically states that the cranial vault is fixed, non-expandable, and there's three components to the intracranial space. So that'll be brain, blood, and CSF. Because the total intracranial volume remains constant, any increases in one of these components must be compensated by a decrease in another. So initially, the body is able to compensate through mechanisms such as displacement of CSF into the spinal compartments or reduction in venous blood volume. However, once these mechanisms are exhausted, small increases in volume can result in a rapid rise in ICP. And in the context of hydrocephalus, the accumulation of CSF disrupts this balance and eventually overwhelms the brain's ability to compensate, leading to raised ICP. So with this physiological framework in mind, we can now go on to define hydrocephalus. So traditionally, it's defined as an abnormal accumulation of cerebrospinal fluid in the ventricular system, leading to ventricular dilation with or without associated rise in intracranial pressure. This definition is more simplistic. Another proposed definition by Rickett in 2008 describes hydrocephalus as a dynamic imbalance between CSF production and absorption within a confined intracranial space. So importantly, it shouldn't be considered purely a radiological diagnosis based on ventricular size. Rather, it reflects a failure of CSF circulation and intracranial homeostasis, a failure of that, which is emphasized in more modern literature. So this distinction becomes important in conditions like normal pressure hydrocephalus, where you can have ventricular enlargement without significantly elevated ICPs. So Hydrocephalus develops, well, the mechanisms of hydrocephalus, it develops where there's a disruption of the regular CSF dynamics, and it occurs through three primary mechanisms. So the first and most common in neurosurgical practice tends to be obstruction to CSF flow, also known as non-communicating or obstructive hydrocephalus. This occurs when there's a blockage within the ventricular system, such as the aqueduct, leading to dilation of the ventricles proximal to the obstruction. The second mechanism is impaired CSF absorption, which results in communicating hydrocephalus. And in this case, the CSF pathways will remain patent, but there is dysfunction at the level of the arachnoid granulation. So that will prevent normal resorption into the venous system itself. This can be seen more so following a subarachnoid hemorrhage or a meningitis. The third mechanism is CSF overproduction, which is rather rare compared to the other two. When it does occur, it's usually associated with choroid plexus tumors, particularly papillomas. So while CSF overproduction is classically described as a separate mechanism, it is also useful to think of it physiologically as behaving like a communicating hydrocephalus, since there's no obstruction to the CSF pathways themselves. So with that in mind, hydrocephalus is classically divided into communicating and non-communicating types, based on whether there's an obstruction within the ventricular system. In non-communicating or obstructive hydrocephalus, there's a physical blockage within the ventricular pathways that will prevent CSF from reaching the subarachnoid space. As a result, the ventricles proximal to the obstruction will become dilated. Examples include aqueductal stenosis, posterior fossa tumors, and colloid cysts. In contrast, you have communicating hydrocephalus, which occurs when there's no obstruction in the ventricular system, and the CSF is able to circulate freely into the subarachnoid space, and the problem lies more so with impaired absorption. This distinction is clinically important as it will directly influence management. For example, obstructive hydrocephalus may be amenable to procedures such as endoscopic third ventriculostomy, whereas a communicating hydrocephalus is more commonly treated with shunting. So beyond simple obstruction or absorption failure, we have to understand how intracranial compliance influences the clinical behavior of hydrocephalus. So intracranial compliance refers to the ability of the cranial vault to accommodate changes in volume without a significant rise in intracranial pressure, which is directly tied in with the Monro-Kelly doctrine we talked about earlier. So in the earlier compensatory phase, the body able to maintain a relatively stable ICP through the mechanisms described before, such as displacement of CSF into the spinal compartment or reduction in the venous blood volume. Once exhausted, small increases in volume will lead to rapid rises in ICP. So this can explain why some patients with hydrocephalus may initially remain asymptomatic, but then deteriorate rapidly. And it also explains why different mechanisms of hydrocephalus can present in different ways, with raised ICP in acute cases or with a relatively normal pressure in chronic conditions like normal pressure hydrocephalus. So acute versus chronic hydrocephalus. Hydrocephalus can present as either, and the distinction is largely determined by the rate at which CSF accumulates and how much time the brain has to compensate. So in acute, there's a rapid accumulation of CSF, and the compensatory mechanisms we discussed earlier will become quickly overwhelmed, which will result in a marked rise in ICP. So patients typically present with headache, vomiting, reduced consciousness, seizures, and a significant risk of herniation if it's not treated urgently, brain herniation. In contrast, a chronic hydrocephalus will develop over time, which will allow the brain to adapt to the increasing ventricular size, and the ICP will basically remain normal or mildly elevated. So as intraventricular pressure rises in hydrocephalus, CSF can be forced across the ependymal lining of the ventricles into the surrounding brain tissue, and this process is known as transependymal CSF flow, which will result in periventricular interstitial edema. So just on imaging, this appears as periventricular hypodensity on CT or hyperintensity on T2 and FLAIR sequences of the MRI. In this image here, the T2 weighted images demonstrate hyperintensity surrounding the lateral ventricles, which is also clearly visible on FLAIR sequences. This is consistent with transependymal CSF flow due to the elevated intraventricular pressures. It's not just again, radiological finding, it will represent intraventricular pressure, raised intraventricular pressure, and reduced intracranial compliance. So it is a marker of active hydrocephalus. So as the ventricles enlarge in hydrocephalus, they will exert mechanical effects on the surrounding brain tissue, particularly the periventricular white matter. This will lead to stretching and disruption of long white matter tracts, which can explain a lot of these symptoms, typical clinical symptoms we see. So, for example, involvement of your corticospinal pathways that can contribute to gait disturbance, while disruption of your frontal subcortical circuits can lead to cognitive impairment. And involvement of your frontal lobe pathways can contribute to urinary dysfunction. In chronic hydrocephalus, there's also progressive cortical thinning and reduced cerebral perfusion. Importantly, many of these changes can at least be partially reversible with appropriate treatment, particularly if you have early intervention. So we can also classify hydrocephalus based on its underlying cause, which is important in planning management. So broadly, causes can be divided into congenital and acquired. Congenital causes include conditions like aqueductal stenosis, which is one of the more common ones, as well as neurotube defects, like myelomeningocele, Chiari malformations, and Dandy-Walker malformations. Acquired causes are more commonly encountered in adult neurosurgical practice. So these will include tumors, particularly those affecting the posterior fossa or the ventricular system, hemorrhage, such as subarachnoid or intraventricular hemorrhage, infections like meningitis, trauma, and post-surgical or inflammatory adhesions. The underlying etiology, again, is important because it directly influences what management will involve. In addition to your classical classifications, there are specific clinical entities within hydrocephalus that are important to recognize too, as they have distinct implications for management. So normal pressure hydrocephalus is characterized by ventricular enlargement with normal or only mildly elevated intracranial pressure. It will present with a classic triad of gait disturbance, cognitive impairment, and urinary incontinence, and it's potentially reversible with CSF diversion. Hydrocephalus ex vacuo, on the other hand, is not true hydrocephalus. In this case, the ventricles enlarge as a result of loss of brain parenchyma, and typically due to cerebral atrophy, that is. And there's no disturbance in CSF dynamics, so there's no role for CSF diversion in those cases. Arrested hydrocephalus refers to a state where ventricular enlargement is present, but it's stable, without progression of symptoms. And these patients may not require intervention and can often be managed conservatively. So taking a closer look at normal pressure hydrocephalus, clinically, as I said before, it presents with Hakim's triad. So that involves gait disturbance, cognitive impairment, and urinary incontinence. MRI would be the imaging modality of choice in this case. So key features you'd see would be ventriculomegaly out of proportion to your cortical atrophy based on age, tight high convexity sulci, and enlarged sylvian fissures. This pattern is often referred to as your DESH pattern or your disproportionately enlarged subarachnoid space hydrocephalus. And your callosal angle can also be useful, with angles less than 90 degrees supporting a diagnosis of normal pressure hydrocephalus. From an investigative standpoint, the CSF tap test is commonly used too, where you have removal of 30 to 50 mils of CSF, which can result in transient clinical improvement. While it is specific, it's not highly sensitive, and you can also do extended lumbar drainage over 48 to 72 hours, which can improve diagnostic accuracy in specific or selected patients. In more complex cases, ICP monitoring can be considered too, although it's not typically routine. Management is primarily with ventriculoperitoneal shunting, which remains the standard of care across international practice. However, outcomes can be highly dependent on patient selection. So patients with predominant gait disturbance and positive response to CSF drainage, they tend to have the best outcomes. And programmable shunt valves are generally preferred to allow adjustment and reduce complications such as overdrainage, which can potentially lead to other complications like subdural hematomas. So with that in mind, how does hydrocephalus typically clinically present? So that will vary significantly based on the patient's age and the rate at which the CSF accumulates. So in infants, the presence of open sutures allow the skull to expand, leading to macrocephaly in raised ICP, or a bulging fontanelle, prominent scalp veins, and a classic sunset gaze due to pressure on the dorsal midbrain. In children and young adults, where the skull is rigid, hydrocephalus typically presents with features of raised intracranial pressure. So that will be the symptoms talked about before, like headache, nausea, vomiting, visual disturbances, often with papilledema on examination. And in adults and the elderly, the presentation depends on whether the hydrocephalus is acute or chronic. So acute cases will present with raised ICP, while chronic cases particularly NPH or normal pressure hydrocephalus, present with cognitive decline, gait disturbance, and the urinary incontinence. So it's influenced a lot by age, the rate of accumulation, and the underlying pathology of it. So I just wanted to also touch on the CT and MRI findings. So CT scanning is typically the first-line imaging modality when you're evaluating hydrocephalus, particularly in acute settings. So in this image here, we can see clear ventricular dilation involving the lateral ventricles and the third ventricle, while the fourth ventricle appears relatively normal in size. This pattern here is highly suggestive of an obstruction at the level of the cerebral aqueduct. And the key features to assess on CT include ventricular enlargement and effacement of the cortical sulci, indicating a raised intracranial pressure. In addition to just obvious ventriculomegaly, there are more subtle signs, or more subtle early signs of hydrocephalus. Enlargement and rounding of the temporal horns are often among the earliest indicators, followed by a progressive ballooning of your frontal horns as the condition continues to advance. Periventricular lucency can also be seen and reflects transependymal CSF flow, which would indicate your elevated intraventricular pressure. Importantly, recognizing the pattern of ventricular dilation is critical, as it can allow for localization of the obstruction. In this case here, the dilation of the lateral and third ventricles was a normal fourth ventricle, localizes the obstruction to the aqueduct. In contrast, if all the ventricles were enlarged, for example, this would suggest a communicating hydrocephalus. Finally, CT as well also plays a key role in identifying underlying causes, such as a hemorrhage or mass lesions, which can be responsible for the obstruction. Moving on to MRI findings, MRI provides more detailed anatomical and physiological information compared to a CT. So it's particularly useful in characterizing the hydrocephalus. So it allows for better visualization of the ventricular system, including the aqueduct and posterior fossa structures, which are common sites for obstruction. In addition to ventriculomegaly, MRI can also demonstrate periventricular hyperintensities on your T2 and flare sequences, reflecting a transependymal CSF flow from raised intraventricular pressure. MRI can help identify the underlying cause as well, such as tumors, cysts, or aqueductal stenosis as well. Advanced techniques such as phase contrast MRI can be used to assess CSF flow dynamics, which can be helpful in selected cases. In the context of a normal pressure hydrocephalus, MRI is particularly valuable as well, as it will demonstrate features such as the dash pattern that was talked about before and a reduced callosal angle. So I just have some MRI images here. So in the first image, which is an axial T2 weighted sequence, you can see marked hyperintensity, a hyperintense CSF signal outlining significantly dilated lateral ventricles. And there's also associated periventricular T2 hyperintensity, representing the transependymal CSF flow due to the elevated intraventricular pressure. In these images, there's a pineal region mass seen posteriorly, which is causing the compression or the obstruction at the aqueduct of Sylvius, resulting in the obstructive hydrocephalus. In the second image in the middle, it's a midline sagittal T2 weighted MRI. The aqueduct is directly visualized here, and there's narrowing at, again, the level of the aqueduct, consistent with the aqueductal stenosis. The third image, one second. Sorry, I don't have my notes here on the third image, but essentially you have dilated lateral ventricles with further dilated lateral ventricles on a flare sequence. So the flare sequence there is suppressing the pre-CSF signal, making the periventricular sign abnormality more conspicuous. So in addition to imaging, there are several advanced diagnostic tools that can help guide both diagnosis and management, particularly in cases where the diagnosis is uncertain. So CSF drainage tests are commonly used, especially in suspected normal pressure hydrocephalus. So as we had talked about before, there's the TAP test in that case. And overall, these investigations help confirm the diagnosis, predict response to treatment, and guide surgical decision-making. So when you're managing hydrocephalus, it's guided by several key factors, which we talked about all before: underlying cause, mechanism, and clinical status. So first, whenever possible, we aim to treat the underlying cause. For example, this may involve resecting a tumor, treating an infection, or addressing hemorrhage. Second, we're aiming to restore normal CSF dynamics, either by relieving obstruction or diverting CSF. And this can be achieved through procedures such as external ventricular drainage, ventricular peritoneal shunting, or ETVs, or endoscopic third ventriculostomies. Third, the urgency of the intervention depends on the clinical situation as well. So acute hydrocephalus is considered a neurosurgical emergency, and that requires prompt intervention to prevent any secondary brain injury. And ultimately, the goals of the treatment is to reduce intracranial pressure, preserve neurological function, and prevent long-term complications. So in acute hydrocephalus, management is, as I said before, a neurosurgical emergency, and the priority is more so rapid stabilization followed by definitive CSF diversion. So initial management focuses on neuroprotective measures, including the airway ABC, so the airway, breathing, and circulation, ensuring adequate oxygenation and cerebral perfusion. And the head should be elevated to approximately 30 degrees, ensuring that you don't have any of the other issues like hypercapnia. The definitive emergency intervention is placement of an external ventricular drain, which will allow for immediate CSF diversion and also enables for intracranial pressure monitoring. Adjunct measures can be used as well too, such as osmotherapy with mannitol or hypertonic saline as temporizing strategies, along with sedation and controlled ventilation when necessary. And then it is also important to address the underlying cause, such as a hemorrhage or mass lesion. Finally, we have to be vigilant for any complications, including infection, hemorrhage during insertion. This is of the EVD, or overdrainage, which can cause, can in some severe cases lead to upward or downward herniation as well. So just to touch on EVDs more, so it's a fundamental tool typically used in acute hydrocephalus management and raised ICP. The primary indications include acute hydrocephalus, as well as conditions such as traumatic brain injury, subarachnoid hemorrhage, and intraventricular hemorrhage, where ICP monitoring and CSF diversion are required. It serves two main functions: drainage of CSF and a means of monitoring for intracranial pressure. Typically, the catheter is inserted at Cocker's points and advanced into the lateral ventricle. From a management perspective, you have to pay careful attention to the drainage level, which is usually set in centimeters of water relative to a fixed anatomical reference point, which is the external acoustic meatus, as well as maintaining strict sterility to reduce any sort of infection. The complications of EVDs include infection, particularly ventriculitis, hemorrhage during insertion, malposition of the catheter itself, or overdrainage, which can lead to complications such as ventricular collapse or herniation. But they are temporary measures and often used as a bridge to more definitive management. So ventricular peritoneal shunting is the most commonly used method of permanent CSF diversion in the management of hydrocephalus. It's primarily indicated in communicating hydrocephalus, chronic hydrocephalus such as normal pressure hydrocephalus, and in cases where endoscopic third ventriculostomies is not suitable or it has failed. So the system basically works by diverting CSF from the ventricular system into the peritoneal cavity. And it consists of a ventricular catheter, a valve mechanism that regulates the flow, and a distal catheter. The valve itself plays a key role in controlling drainage, and programmable valves are often preferred as they allow for postoperative adjustments and they reduce complications related to overdrainage or underdrainage. Shunts can be associated with significant complications, with infection being the most common in the early postoperative period, while obstruction is the leading cause of longer-term failure. And as with EVDs, overdrainage is another important complication that can result in overdrainage complications like subdural hematomas or slip ventricle syndrome. So as a result of that, especially with the complications, patients with VP shunts require long-term follow-up and may need revision surgery over time. So in addition to your ventricular peritoneal shunts, you have alternative CSF diversion pathways that can be used in selective patients or selected patients. So ventricular atrial shunts divert CSF into the right atrium and are typically considered when the peritoneum is not suitable, such as cases of a prior abdominal surgery or infection. However, they carry risks including infection, thrombosis, and cardiac complications. And you also have lumboperitoneal shunts to divert CSF from the lumbar subarachnoid space into the peritoneum, and they're primarily used in communicating hydrocephalus, particularly in NPH. LP shunts are associated with complications such as overdrainage, low pressure headaches, and in some cases tonsillar herniation as well too. These overall, these alternatives are more so useful in specific situations, with ventricular peritoneal shunting remaining the standard approach in most cases. So there's also endoscopic third ventriculostomies. So it's a physiological method of CSF diversion that aims to restore normal CSF pathways rather than diverting the fluid externally. So this procedure involves creating an opening in the floor of the third ventricle, which allows CSF to bypass an obstruction, such as at the level of the aqueduct, and flow directly into your basal cisterns. ETVs are particularly indicated in obstructive hydrocephalus, as I had said before, in aqueductal or posterior fossa tumors. And one of its major advantages is that it avoids lifelong shunt dependence and it carries a lower long-term risk of infection. However, it's not fully without complications. Failure is a significant concern, especially in younger patients, and there's a risk of injury to critical structures such as your basilar artery or your hypothalamus. So for ETVs, patient selection is very key in deciding whether you could do it or not. So the choice between endoscopic third ventriculostomy or VP shunting depends on the underlying pathology, patient-specific factors, and dynamics of CSF flow. So ETV, again, preferred most in obstructive cases when there's a clear blockage. In contrast, VP shunts typically used in communicating hydrocephalus, where the issue lies with absorption rather than obstruction. So shunt failure is a common and important clinical problem with the ventricular shunts. And it should always be considered in any patient with a shunt-in who presents with neurological deterioration. So the patients will present with or can present with headaches, vomiting, reduced consciousness, or occurrence of their previous hydrocephalus symptoms, so symptoms of raised ICP. An assessment will begin with imaging, typically CT, to evaluate the ventricular size, and a shunt series to assess the continuity of the system. And in select cases, a shunt tap can be performed to assess function. The most common cause of shunt failure is obstruction, although infection and mechanical failure can also be considered. And your management will depend on the patient's clinical status. So in unstable patients, urgent CSF diversion with an EVD might be required, with definitive management being identifying the level of failure and then performing a shunt revision or replacement. So to summarize, hydrocephalus is fundamentally a disorder of CSF dynamics and intracranial compensation rather than just purely ventricular enlargement on imaging. And it arises from the imbalance between production, circulation, absorption. And it's influenced by the brain's ability to compensate for changes over a shorter or longer time. So understanding this mechanism is crucial, and your management must also be tailored to the clinical context. So ultimately, good outcomes here in this case would depend on early recognition, appropriate patient selection, and a timely intervention. So with that, that's the end of my presentation, and these are my references. Thank you.